Good afternoon and good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest, who is from the UAE, Professor Mohammed Al Ulama. Professor Al Ulama is a pediatric and functional neurosurgeon at the Rashid Hospitals, Dubai Health Authority, and Valiant Clinic and Hospitals, Dubai. He is the president of the Emirates Society of Neurological Surgeons and president of the Gulf Neurosurgeon Society. He is the General Secretary of the Arab Pediatric Neurosurgical Society, and he was the ex-Vice President of the Emirates Medical Association and ex-member of the Emirates Scientist Cabinet. We are extremely honored to have him today at our webinars, and we are extremely grateful to him for accepting our invitation to be a speaker today, and he'll be talking about endoscopic craniosynostosis repair. The speaker for the second session of today is our honored guest from Istanbul, Turkey, Professor Onur Yaman. Professor Yaman is an associate professor at the Memorial Health Network, Istanbul, Turkey. His clinical practice is focused mainly on the spine surgery, and he is a member of several important organizations, including the Turkish Spine Society, Middle East Spine Society, World Spinal Column Society, Eurospine Society, AO Spine, and SRS, Scoliosis Research and Treatment Association. He has won numerous awards throughout his career and is a noted researcher with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to be a speaker at our webinars today, and he'll be talking about adult degenerative scoliosis. The chair for the first session of today's webinar is our distinguished faculty from Japan, Professor Nobuhito Morita. Professor Morita is the director in the Division of Pediatric Neurosurgery at the Kitasato University School of Medicine, Sagamihara, Japan. He is a world-renowned faculty in the pediatric neurosurgery who has published several important landmark papers in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Al Ulama. The chair for the second session of today is our honored guest, who is also from Istanbul, Turkey, Professor Salim Sentur. He is an associate professor at the Memorial Health Network, Turkey. He is particularly interested in endoscopic spine surgery and deformity surgery. Dr. Sentur's research focuses on spinal pathology and newer techniques in spinal surgery. He is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him to have accepted our invitation to chair the session of Professor Onur Yaman. On behalf of the Education Committee of the ACNS and the President, Professor Yokub Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would hand over this online podium, directly go to our first speaker, Professor Mohammed Al Ulama.
Thank you very much. It's always my pleasure and honor to be with you. So I work at Rashid Hospital, which is a trauma center mainly, but we deal with also vascular cases. But 60% of cases are trauma, and rest are the tumors with bleedings, with midline shift, and acute phases. So today I'll talk about craniosynostosis. And we'll start a little bit briefly about the craniosynostosis in general. So it is a premature closure of one or more of cranial walls of cranial base sutures, and it imposes restrictions to the growth of the underlying brain, resulting in compensatory growth and expansion of less restricted areas. And the prevalence is 1 in 2,000 to 1 in 2,500 births. And the distribution, most common, is the sagittal craniosynostosis between 40 to 55%, and next common is the coronal between 20 to 25%, then metopic 5 to 15, and lumboid 0 to 5. Then comes the multiple sutures 5 to 15%, and they are mainly syndromic, and I will not go through these type of craniosynostosis today. So the first people who will see the defects in the pediatrics are the pediatricians, and always during the vaccination. And then you could palpate the overlapping sutures and the ridges of the fused sutures. And then you have to do a CT, which is the standard to see the and diagnose the craniosynostosis. And we have to know that during the first year of life, the brain will triple in size, followed by slower growth until it reaches full size in the teenage years. Restriction of this growth may have functional consequences. An elevated ICP or intracranial pressure occurs in approximately 47% of patients with multiple suture synostosis and in 14% of patients with single suture synostosis. And then we have, at that time when the ICP is high, many issues like blindness with optic atrophy and corneal exposure, hydrocephalus in syndromic patients, developmental delay, abnormality of speech and hearing, abnormality of airways when they have mid-face intrusion in syndromic cases always. And also we can have this at a later stage with the beta and copper canium, and the left side with the CT and the right side with an X-ray. And these are the most common types of craniosynostosis. On the left side, we start with the triangular permanent forehead trigonocephaly. Then we have the brachycephaly with bilateral coronal sutures. Then we have plagiocephaly, posterior plagiocephaly and anterior plagiocephaly. And then we have also the scaphocephaly, which is the both head with sagittal craniosynostosis. And we have to remember the positional brachycephaly of positional molding of the head, and we have to differentiate between this and the lumboid plagiocephaly. And what we need to do then is only to look at the head from the above and look at the flattening of the head posteriorly, at the same time bossing of the frontal with the ear pushed forwards, and this is always a positional. In the lumboid craniosynostosis, the flattening is not in the same side at the bossing of the forehead, and also the ear is pushed backwards. So I want to share with you our experience in craniosynostosis. Actually, this took us almost 10 years to start these procedures. As I mentioned, our hospital, Rush Hospital, is mainly for trauma, but we did a lot of pediatrics. The problem was that we had no pediatric ICUs, and we had to do our pediatric cases in another hospital called Latifa Hospital, which was obstetrics and pediatric hospital. Recently, we opened a new hospital. It's called the Jalila Hospital, which is a children's hospital. And then in 2021, I met Dr. Derek, who is a pediatric plastic surgeon who had a lot of experience in craniosynostosis repair. So then we started to build a team between me and him in 21. And then we made a group of different specialties, which I will come to very soon. So the background about the endoscopic craniosynostosis is that it is a minimally invasive option, and it was recent, is a recent advance came by Dr. David in 1998 when he published this. And in UAE, we are the only team which are performing these surgeries. This is the publication by Dr. David Jimenez and Baron. And on the right side, this is the book with the illustrative cases, which you can learn a lot of. And this is our team. On the left up is Dr. Alex from Germany. On the right is me, sorry. Lower down on the right is Dr. Marco, the ICU care doctor, and on the left is Dr. Derek, the plastic surgeon. So we work close together always in these cases. This is our team in the OT doing one of the cases. And usually the endoscopic craniosynostosis repair done between 3 and 4 months, very rarely at 5-month age. So the cuts we do in the skin are small, and we remove the bone with help on the endoscope. Very minimal blood loss, and they usually stay in the hospital up to 3 days, and they have quick recovery. But the only thing is that they need a helmet. They have to have a helmet, special helmet, and they need to have it 24 hours a day for at least 1 year to get the correct shape of the head. And actually, this is not a big problem. The small kids, they get used to it. Some parents, they think that it keeps the head little warm. You know, the climate in our country is hot and warm, so this is the only issue with the helmet that they have. Otherwise, there are no issues. They can live with it, sleep with it, no problems. The aim of the study that we had was to investigate the clinical and morphological outcomes of all patients undergoing the endoscopic craniosynostosis surgeries, and to document the first prospective case series of patients with the multidisciplinary team approach from neurosurgery, anesthesia, critical care, and plastic surgery. So we had 16 cases. Now we have 18 cases actually. The first case was done in May 2021, and the data collection was of these 16 cases. Pre-inter and postoperative data, pictures, pre and post-surgery, head circumference and head measurements was done. The cranial index by parietal diameter on anterior posterior diameter, head circumference, and cranial vault asymmetry index was measured on all these cases. So this is the cranial index. We measure the parietal on anterior posterior diameter, and usually they are between 75 to 85% in normal cases. In scaphocephaly, they're less than 75, and brachycephaly, they're more than 80%. And this is the cranial vault asymmetry index, and it in normal cases should be around 1. And these measurements done by laser scan. So the age of all patients at the time of surgery was 101 days. So between 90 to 117 days. The mean duration of surgery was 70 minutes, 38 to 129 minutes. So the more experience we get, the faster we are getting. The mean blood loss was 180 to 200 ml. Mean duration of hospital stay was 4 days. The mean ICU stay was 1 day, and no complications and mortality were reported. Why our patients were stayed in ICU is because we had no high dependency rooms in this hospital. But as soon as we have them, then they will be only treated the first day in high dependency. At the moment, they all go to ICU. So this is the cranial index pre and post surgery. So before surgery, and the blue on the left side, it was around 65, and after surgery between 80 and 75, which is almost normal. And the cranial vault asymmetry index pre-surgery was near to 10, and post-surgery close to 1. So we start with some cases. This is a right-sided unicoronal craniosynostosis. As you see in this chart, this is the CT 3D model shows clearly the craniosynostosis on the right side. And this is the surgery, and this is our incision. We used at the beginning to do to put an incision parallel to the midline near to the fontanel, and the other one a little lower down where the hair is there, and then we go through these two openings and remove the bone. But later on, we started do this linear incision, so it is, it's much easier to see our field during the drilling procedure. And we used to go all the way to the anterospinal suture and to the supralateral angle of the orbit, which gives better correction. And this is the child with the helmet after measurement, and here there is a circumference, following the normal size. This is the same child at the age of 9 months, and you can see the difference in the shape. And later I'll tell you that the unicoronal, it may take a longer time to be corrected, maybe after 5 years. And this is after 1 year. So Dr. Durek published his experience about the idea that we better go to the supralateral angle of the orbit with the bony removal, because the anterospinal sutures usually in these cases, in most of the cases, also fused, and it's difficult to know where to end with the bone removal. So it's easier to go all the way to the supralateral angle of the orbit. And as you see, in this case, with the coronal stenosis, the anterospinal suture is also fused and it's going closer to the orbit. On the other side, which is normal, you can differentiate between the anterospinal suture and the coronal suture. So it's easier in that case to go all the way to the supralateral angle of the orbit, and also to get better correction later on. I forgot to tell you that the thickness of the bone that we remove is always 2 centimeters. And this is the case, which, goes all the way to the orbit. This is a sagittal suture craniosynostosis with the both head. And this is the way we put the child in a sniff position, not much extension of the neck. These sutures are, we put 2 sutures. The first one is a little bit posterior to the anterior fontanelle, the other one anteriorly to the posterior fontanelle. And also we tried with the lazy S, and we found that lazy S is much, much easier to have in these cases. And this is the child after the surgery. And then we send them later on for a laser scan to measure the head to get the helmets. And these helmets we buy from US actually after sending them the readings for the size. And this is the same child after 1 year. And this is a video that shows the sagittal craniosynostosis repaired by endoscopy, which I would like to share. This is by Dr. Smith and Dr. Patil. So I would like also to share here some of my experiences during these now 19 cases. Actually, we don't extend the neck so much for these procedures for the sagittal sutures. And endoscopy is very, very good in, cauterizing the veins and all the strokes, which puts the sinus adherent to the bone. Usually, in this group of the children age 3 to 4 months, there is no much adherence. But in case there are adherence, the endoscopy will show you it, and you can, remove the adhesions smoothly without any bleeding. I started my cases with caissons and also scissors, but I found that these causes a lot of bleeding from the bone. So we saw that these doctors, they're using the caisson and scissors, so these causing bleeding. From my second case till now, I'm using the diamond drill. So when you drill the bone, at the same time, you stop the bleeding with the drill. It helps a lot actually in controlling the bleeding. And at the same time, you use a spatula to hold the dura away from your drill. One more thing is very nice to have is the taco seal in case the drill causes any small hole in the dura with CSF leakage or any bleeding from the sinus. The taco seal will be very nice to put on and stop the bleeding, or also the CSF leakage. Thanks God I never had any sinus bleeding, but this is the key to use. And I advise you never use the flow seal on the sinus. In case the flow seal goes into the sinus, you will end up with the sinus thrombosis. So better to avoid it on sinus. Otherwise, in the dura, other sides of the dura, when you have diffuse bleeding, it will be very good to have. So we roll on. This is a case of metopic craniosynostosis, which we also used the endoscope, and we did a very, very minimal small incision anteriorly to the fontanel at the edge of the hairline, with very nice outcomes. This is the child, and this is 9 months of age. So we had also a case of left frontosphenoidal craniosynostosis. Usually these cases are not treated by many of the doctors, but we thought that this case had a really bad defect. So we took this child to surgery and operated, and we also published this case. So regarding the complications, we had no infection, bleeding only in one case, which needed some transfusion, and that was in the trigonocephaly case. We had bleeding from the bone actually. CSF collection post of 0, scar alopecia in 2 cases, no mortality. Patients will be soon managed in high dependency units instead of the ICU. Delayed result, incomplete correction, commonly seen in unicoronal craniosynostosis, as I mentioned, and can take up to 5 years to get good results. So key learning points here: the best results are seen when surgery is done at 3 months, when the bone is thinner and malleable, and in sagittal synostosis, much less adhesions. Ensure the whole suture is removed to the next suture line, minimum 2 centimeter strip. Close cooperation and follow-up with orthotist is a key. They can detect any early pressure effects. Endoscopic technique is well suited for sagittal and metopic craniosynostosis, as well as for coronal and lumboidal synostosis. Blood loss can be minimized with special long surgical instruments and insulated diathermia, and diamond drill could minimize bony bleeds. Then I would like to show you some pictures of the laser measurements for these helmets. So they get this special cover of the head, and then they get the readings, the key lines measured, and the measurement sent to a company in US where they make the helmets and will send it to us. And these are the helmets, and usually they change maybe once or twice the size of the helmet, because when the head is growing, the inner side could be removed or scratched away by your orthodist. So it will fit the head when it grows till the time they need to get a new helmet during the year of usage. There are different sizes and types and colors which fits the heads. And as I said, these kids tolerate its head in 24 hours also during when they sleep. So no issues with the helmet actually. In conclusion, early intervention less than 6 months of age with the endoscopic. Minimal invasive surgery is safe and effective in complete correction and non-syndromic craniosynostosis. Technical tip in unicronal craniosynostosis improves forehead correction. Metopic and sagittal craniosynostosis patients are ideally suited. Orthotists should be part of the craniofacial team, and close cooperation essential to success. Thank you very much.
Thank you very much. Our Honorable Professor Morota has joined us. Professor Morota?
Yeah, I'm sorry to be late. I have said, I enjoyed the presentation very much. It's excellent. But I do have several questions about the presentation. The first question is when you operate for the unicoronal craniosynostosis for the coronal suture, you go down to the orbital rim?
Yes, orbital angle, yes.
So that's the reason why my impression about your skin change is a little bit longer than usual skin change for the coronal synostosis. I mean, endoscopic coronal suturectomy. I do 2 centimeter transversal skin incision and then go down to the asterion. But you go down to the orbital rim. That's the reason why you make a longer skin incision. Is that right?
Yes, exactly.
Yeah. Okay. Thank you very much. And the next question is when you coagulate the bone age.
I don't coagulate actually. I use the drill, so I don't need to coagulate because the bleeding is much less. But if I still get some bleeding, I put only the bone wax. Yeah, that was in a video from some colleagues. Yeah.
Yeah. Okay. Because your video presentation, there's no narration. I was unable to hear the narration during the video presentation. So just I wonder how you made the hemostasis just only for coagulation by monopolar coagulation, or you do something else. That was my question.
Yeah, it's the drill, the diamond drill will stop the bleeding by itself. Is the same in the skull-based surgeries. When you drill the bone and it comes bleeding, you still drill, and then you get this stop of the drilling of the bleeding by the drill. So this is the same concept. And if you still have some bleeding, then the bone wax will do the job.
Okay. And the next question regarding the metapic suture synostosis. When you go down near the frontonasal suture, probably it's very difficult to reach there. And you need to compress the frontal lobe or do something, there's some very steep curve. Do you have any comment about it, the technical comment or technical recommendation about how to reach there?
Actually, we had for the metopic, we had only one case, and this case we had to stop because of bleeding. That was the only case we had bleeding from the bone, so I could not reach to the suture. So we decided to stop for this case. That was the beginning of our series. It's metopic is very rare in our country. Our country, we have 200 nationalities, so more coronal than sagittal actually in our series. Because there are different nationalities, they are here, so we cannot give any statistics actually about the cases or the prevalence and stuff. So metopic, we had only one case, and that was the issue. So yeah, I agree with you. It's difficult, but I think I use the thinner for that case. I use the thinner spatula, and when I reached the end, I used the pen field. Pen field to release the dura from the bone. But then, as I said, I had the bleeding, so I had to stop on this case.
Right. And the next question is about sagittal synostosis. You make only a rectangular shape of the suturectomy. You don't go to the lateral, to the some part of the coronal suture or some part of the posterior lateral direction. You don't go, right?
We on our we had one case which we did when we started with the lazy incision. When we had the lazy, it was very easy to go laterally to the parietal bone, and frontal, and go down to the temporal. We did that.
Okay.
Yeah, at the beginning when we started with these incisions, on the fontanelles, it was very difficult to go laterally down.
Okay. And my last question is the duration of the helmet therapy. How long do you apply the helmet postoperatively?
1 year.
1 year.
Yeah.
So that means you need to modify the size of the helmet several times during that period.
Yeah.
What's the coverage of the cost? The parents pay for that?
Okay, for I actually don't know about the insurance, but for our local patients, the government covers for the helmets. For the non-locals, I'm not sure about the insurance. But this helmet, most of our cases they change only once, because you can remove the inner part. Every time they grow, they remove the inner part, so they adapt the size from inside.
Yeah. Okay. Thank you. So I really enjoyed it and appreciate your presentation. Thank you very much.
Thank you. My pleasure.
Thank you very much. We enjoyed a lot too. It was really informative. One question I would like to put across to that endoscope is specialized for pediatric craniosynostosis, or it is a normal one with that we use?
Yeah, it's the same that we use, for the ETV and stuff. We use the same endoscope.
But I saw a handle which was when you held it, it was inverted. The handle.
Okay. No, this video is from colleagues. It's not our video, unfortunately.
Fine. Understood. So thank you. Yes, Professor Morata, please.
Okay, I have one comment again. That's erosion. You retract the skin by spatula to elevate the skin flap to make a space, right?
Yes. Yeah.
Yeah. What I do during the endoscopic suturectomy is I usually use a syringe, the 20 cc syringe. I cut both ends and then cut half, so the syringe becomes a dome. So you can insert it under the skin, so you don't need to elevate skin so much. The one hand becomes free. It's
very nice.
Maybe
very
you
nice
you can try it next time you have a case.
I will do, absolutely. Thank you very much.
You're welcome.
That is a wonderful tip, and we are extremely grateful to Professor Morata to bringing out that beautiful tip. So I think we'll wind up the first session for now. I understand Professor Mohammad Al-Ulama is traveling today, so we'll excuse him for after this session. Before he moves, I would like to mention to our viewers that this webinar is being broadcasted on WeChat, YouTube, and Zoom, thanks to Professor Shubin. And today, as of now, we have around 400 people who have joined us live from across the world. So thank you very much, Professor Morata and Professor Mohammad Al-Ulama, for coming here and teaching us nuances about craniosynostosis. Thank you very much. We'll move on to the second session, and I will hand this platform over to our second chair, Professor Salim Center.
Thank you so much for inviting us to chair this meeting. To the second section, we will talk about Adult degenerative scoliosis, Dr. Onur will talk about this topic. Dr. Onur, may you start?
Hello, Salim.
Hi, welcome.
First of all, I'd like to thank Raja and all the organizing committee for this kind invitation. I'm a neurosurgeon from Istanbul, Turkey, but I'm in Pakistan now for a meeting, and I'm just attending the meeting from my hotel room. Hello to everyone. So it was really a very good presentation, the craniosynostosis topic. So I want to talk another complex surgery about adult degenerative scoliosis. So we are doing some cases like the patient was like that, and after that the patient was corrected a severe kyphotic case. Then another case that has a severe coronal imbalance and adult degenerative scoliosis at the lumbar area. So to manage these kinds of patients, first of all, we have to decide what's the complement and when did the day started, and are we going to just treat the pain, or are we going to correct the deformity? What kind of surgery we are going to need? We will analyze the deformity and what we have to correct, and if you have to correct that levels, which levels do we have to choose? So first of all, I want to give you an example. This case was walking very well 1 week ago. Then something has started. So you see the pattern of the walking here. So if you look at the X-rays and if you look at the lumbar area, you may see a scoliosis at the lumbar area, and you will see there is a sagittal imbalance. The SVA is 17 centimeters. If you look at just the films, you may treat that patient incorrectly, because the cause of the deformity is just according to the pain. If you just solve the problem, you will correct that patient. This was before the surgery and this was after the surgery. So another case was 55 years old, has back pain. And if you look at the sagittal plane, the patient has sagittal imbalance. But the reason of that imbalance was just a disc, and we have removed that disc. And after the surgery, the patient's sagittal balance has been balanced. So the spine has a language. We have to know it and we have to analyze it. If you look at just this film, you may say that the patient has a straight lumbar lordosis. He has, or the patient has lost the lumbar lordosis. She has bended the knees. The S1 is parallel to the floor. The patient is using the pelvic tilt. She tries to compensate the sagittal plane. And if you look at the thoracic area, the patient has a hypokyphosis. So all these means the patient has a sagittal imbalance. So the patient is trying to correct the sagittal plane. So we have to look at the scoliosis films, also the AP and lateral films. In the picture at the midline, there is no problem, everything is fine. And if you look at the left side films, so everything is very clear. The patient has sagittal imbalance, but the main problem here is the patient that's on the right side, because everything seems very good. The SVA is fine, but if you look at the pelvic tilt, you may say that the patient tries to compensate the mechanisms, using the compensatory mechanisms, and try to balance the spine. These are the difficult patients. So you have to take care for that patients that have increased pelvic tilt. So we may say that SVA is not enough for that patients. So another thing that we may say that this classification, Bariano-Lamartine classification, is a good classification to determine which levels. It doesn't give us an exact levels that we have to start and stop, but it gives us a main idea about the deformity. The first one is the examples that I have given you in the first and second one. The problem is far away from the apex. Type 2 are the deformities that includes very small levels, very less levels, and type 3 is the levels that you have to fuse more. But the more difficult types are sagittal and the coronal imbalance patients. So before starting to correct a deformity like this, you have to say that patient and the relatives that you're going to have a problem in the future, because the complication rate of the spinal deformities, the adult ones, are 40%, and half of your patients may need a revision surgery. So if you talk and if you give this details to that patients, they can make a decision for that. So we have to know the sagittal parameters, the sagittal balance concept. After the surgery, on the right side, you may see that the SVA has to be less than 4 centimeters. The difference between pelvic incidence and lumbar lordosis has to be less than 10 degrees, and the pelvic tilt has to be less than 20 degrees. But if you have very high pelvic incidence, the difference between pelvic incidence, you have to decrease the lumbar lordosis 10 degrees. And if you have a low pelvic incidence, you have to add 10 degrees to lumbar lordosis. We know that the lumbar lordosis distribution is 2/3 of them at the distal part, at L5, L4, L5, and L5, S5. This is true when the patient has a normal pelvic incidence, but if the patient has a high pelvic incidence, the distal part needs less distribution of lumbar lordosis. But if the patient has low pelvic incidence, the lumbar lordosis distribution is more distal. So another parameter is also the age. We can say that if a patient is more older, if the patient is elderly, the difference between pelvic incidence and lumbar lordosis is increased, and you don't need too much SVA to correct it more. So if you look at the table here, over 75 years old patient, you don't need SVA less than 4 centimeters. 8 centimeters is acceptable. So we have to know all these parameters. Without knowing that, we cannot make a plan before the surgery. So we also know the concave and convex coronal imbalance parameters. So how to make a decision before the surgery? So we need a sagittal plane and also the coronals, the scoliosis films. So we want to correct that patient. So we have to apply an osteotomy. Without osteotomies or adding interbody cages, you cannot correct that deformities. So we are using the SurgiMap software. So we are trying the osteotomies at different levels. We have started with pedicle subtraction osteotomy at L4. So when you apply an L4 pedicle subtraction osteotomy, it will not be enough for you because the SPA is 17 centimeters. So we have added a Ponte osteotomy. You see the SPA is not still enough. So we have added one more Ponte osteotomy, one pedicle, and 2 Ponte osteotomies. SPA is not enough. Then we changed the type of the osteotomy. We decided to make a corner osteotomy at L4. It's still not well enough. We had a Ponte, then another Ponte. At the end, we have decided to make a double Ponte osteotomy and a corner osteotomy at L4 level. So when you're using the SurgiMap, you can also decide the shape of the rod. We have decided to fix this patient from T10 to the iliac wings because if you decided to make a L4 level osteotomy, you need 2 more distal fixation points. So you have to go to S1. You may decide to make it to L3, but if you make that osteotomy at the L3 level, it will be not enough to correct it, to protect the fused S1. It's not enough. So we have decided to go to L4. And the fixation levels were T10 to S1 and also the iliac fuse. The shape of the rod has to be like that. So we are using the pre-bending rods. This is the shape of the rod that we have decided to apply during the surgery. we gave the length of the rod and also the shape of the rod so that they can bend it before the surgery. This was the drawing of the rod before the surgery. They have bent it according to our shape. So these two rods were ready before the surgery. So it helps you to reduce your surgery time because you don't have to spend time during the surgery. So this is the intraoperative views. We have added cement, and we also done the osteotomies that we have planned. So these are the two different X-rays of that patient. So we have measured it. If we really have the proper lumbar lordosis, because we have, if we come back, we have planned to make the osteotomies, and these two osteotomies will give us a 39 degrees lumbar lordosis during the surgery. So in the surgery, we had 38 degrees lumbar lordosis. We have measured it from the upper part of L1 and upper part of S1. So these are the clinical and radiological films of that patient. This was before the surgery, and this was after the surgery. So this was our plan, 39 degrees lumbar lordosis. We had 33 degrees lumbar lordosis. We couldn't reduce the pelvic tilt. If we could add a pillow during the surgery under the hips, I think we can reduce that pelvic tilt. This was our mistake during the surgery. This is another case, 60 years old female, backhand bilateral leg pain, bends forwards in time. The neurological examination was normal. These were the necessary measurements before the surgery. Again, we have decided to apply a coronal osteotomy at the L4. Coronal osteotomy means you remove the pedicle, you come to the upper part of the disc, you remove the disc, and you also remove the disc, and also you have to apply an interbody cage inside. So then you close it. It allows you to correct the lumbar lordosis for 40 or 50 degrees. These are the intraoperative views. We have done discectomy, we removed the pedicle here. We have applied an interbody cage at the below level. Then we have closed it. And this is after the surgery. Another case that has been done before had, I think, 2 or 3 times lumbar disc herniations. So I have heard the word, the sentence, but I cannot remember who has said that. Every spine surgeon is a deformity surgeon. Someone creates the deformity and someone corrects the deformity. If you look at the shape of the rod, they have put it straight. So if you fix it, you have to deal also with the lumbar lordosis. So it's a iatrogenic deformity because of the adjacent segment diseases here. In time, the patient has a lumbar kyphosis here. And as we talked at the beginning, the patient is using the compensatory mechanism to balance the spine. So we again make the necessary measurements, and we also have used the pre-bending rods here. So this is the intraoperative views. We are also using a T-rod during the surgery to see if we have corrected the coronal balance or not. Intraoperative views of that patient. You see, we have combined 3 different C-arm views during the surgery. We are putting the T-rod, and we want to see that T-rod so that it has to be between the rods that we have applied inside. If the rod is coming outside of this rods, it means the patient has a coronal imbalance. And another trick point here is the L4 has to be parallel to the floor to maintain a good coronal balance. And this is postoperative clinical and radiological film of that patient. So another technique that you're using during our surgeries is the kickstand rod technique. So as I said before, these kind of surgeries may need revision surgeries, and you may have complications. We have applied a kickstand technique here. Everything was fine on the sagittal plane, but if you look on the coronal plane, we couldn't correct it, and you will see that we have lost one of the rods here, the screw heads here. So the patient's has a still coronal imbalance. So we have revised that patient again. This is the technique that you have to use for the coronal imbalance cases. You can add an extra rod, a screw on the iliac link with an extra rod. Just applying the distraction maneuvers, you can bring that patient in the midline. Like a tree, you can bend it onto the midline. So this is the intraoperative view. This is the cranial part. This is the caudal part. This is the right side. This is the left side. The patient is deviated on the right side. So we are opening it to make it faster. So we are removing the direction of the screw. We are making it perpendicular. Then we fix the screw head on the iliac wing. We lose all the screw heads on the right side. Then we're using a strong rod holder. We're fixing it. We apply the rod holder and we just distract it. And with the helping of a domino here, we're just bringing the patient from right side to the left side. So if you look at the coronal plane, the patient is very good. But if you look on the sagittal plane, because of the distraction maneuver, we have lost the sagittal balance. The patient has come a bit forward. So if you apply, let's think that the patient is on the coronal imbalance on the left side. If you apply a maneuver, the patient will come to the forward. But if you apply an extra rod, and if you apply a compression maneuver on it, you can bring that patient to back. This is a tie rod technique. So these are the examples that we have done in different cases. We're using double rods to maintain the strength of the rods, the system, and also to get a good coronal balance. These are the intraoperative views of that patient. Another patient that we have applied double rods on right side and left side. So my keynotes are, we have to decide what we are treating. Are we just treating the pain? We have to take care for the complainants. We have to talk before the surgery, all the complication rates, the revision rates, because again, these kind of surgeries may have 40% complication and you may need revision. And I think in the future, these kind of surgeries can be treated by minimally invasive techniques. Thank you so much for your attention.
Thank you so much, Dr. Onur. It is great presentation. I have a question about this presentation. And what do you think about osteoporosis? We know these patients get a severe osteoporosis. Is there any algorithm for this type of patients? What is your plan?
So, one of the main problems that increases the rate of the complication is osteoporosis. So some of our attenders doesn't know, but we're doing the surgeries together. So these kind of patients, the main problem is osteoporosis. We are trying lots of things. We are, as you have seen, we are applying vertebroplasty in most of the cases. Sometimes it reduces the complication rate, but this is not the solution. We are trying to do some hybrid techniques. We are trying to add some dynamic systems on the upper part. We try to make a soft passing to the upper part. Sometimes we are using the bends to reduce the stress on the top. Maybe we can solve the top problem, but just adding the iliac wing screws, we have seen that they are not solving the problem.
Yes.
So you are a good, also minimal invasive surgeon. I think in the future, these kind of surgeries can be solved with minimal invasive techniques. because
Yes.
just increasing the fixation levels will not solve that problem. The first two cases, except the first case, the second and the third case, we have also revised that because of the proximal junctional failure, one of them because of the rod breakage. So we have to reduce the surgeries, but if we can, we have to reduce the levels, because just increasing the levels and adding some vertebroplasty techniques, they are not the solution. And all of the world is just trying to solve that problem.
Yes, it is a severe problem. And another question, maybe we may talk about the dynamic system for the treatment of these type pathologies. Do you advise this dynamic system to treatment of adult deformity surgery? Or the other question, which kind of deformity patients we can perform dynamic systems, if possible?
Not dynamics system we are using it, but it's not a final solution for that. The patients, especially at the 4A and 4B, are not suitable for dynamic instrumentation. Maybe type 2 or type 3 are suitable for that patient. I mean, the patient who doesn't have coronal and also sagittal imbalance may be the candidates for dynamic instrumentation. And we have seen that when you're using the dynamic instrumentations, you may not have too much problem at the short levels. But if your level is increased, you may have also problem at the dynamic systems. I think, and also I want to ask to you, what do you think about the minimal invasive techniques that can be applied in adult degenerative deformity cases? What do you think about the minimal invasive?
Yes, it is a maybe feature. It will be a most popular approach for the treatment of this type pathologies. If you solve this problem, this minimal invasive or X-leaf, O-leaf, A-leaf from the anterior or anterolateral approach, you can put the screw all rows from posteriorly and percutant. You can solve this type problem easily, and you can protect the whole structure without touching any muscles or any other tissues. It's another option.
And we can also reduce the fixation levels for using the minimal invasive techniques.
Just you may focus the apex of the deformity if you use the minimal invasive approaches. It is an option. Yes. And thank you so much for this great presentation.
Can we see the questions?
There are none so far. Nobody has any questions yet.
So everybody has understood it very well.
Yes. I would like to ask one question. How can you combine the C-arm images? Is it on the C-arm, or you take that image and you do it on a computer?
Look,
how do you do it?
Can you see the screen again?
No, you have to share. Yes, now we can see.
Yes.
Look, let me make the full screen. Look, these are three different C-arm views, okay?
Okay, so you have copied it on a USB and put it...
We just put it on the computer, okay? We make the necessary measurements. Another example is here. Look, this is three different, one in the thoracic area, one in the lumbar area, and other one is in the lumbosacral junction here. We just get them, we put it together, we combine them, and we make the necessary measurements during the surgery. Also, the lumbar lordosis. We have decided to make a lumbar lordosis for 39 degrees. Let me show you. So this one is including the L1 upper end plate, and this one is including the S1 end plate, because all of you cannot get all the vertebrae from L1 to S1 just with a C-arm view. So you have to combine them. So you may know that if you make a surgery like that, at the end of the surgery, the lumbar lordosis will be like that. So we have seen that the lumbar lordosis were nearly to it, just 1 degree from it, far away from the that we aimed before the surgery.
Okay, so it is the software SurgiMap which does this,
Yeah,
right?
no. The
No.
software is the program that we are making all the calculations before the surgery. Okay.
For the surgery.
Okay. Okay.
So we are putting all the necessary views that we are going to measure it. Then we have measuring it on the system. Just putting it, and it says that draw a line from L1 to S1. It measures it and gives you on the screen.
Well, thank you very much. We did not know that it is so much of complicated calculations and all you have during scoliosis surgery.
Yeah, we all the time we need a plan. Okay, if you let's think about uh, building. Okay, if you don't have a plan, okay, you cannot do the building. If you want to just make a desk, you need a plan. You need the measurements. Okay, if you do the surgeries, the complicated surgeries, you cannot say that I have bended the rod according to my eye. Okay, because in our residency, we were asking to our teacher, is it this rod well bended? They say that yes, bend it more. So how do we decide it? Just with our eyes, it's impossible. So every patient needs a different lumbar lordosis. Okay, so we have to know the sagittal balance concept. So your pelvic incidence, if you're, I'm talking it basically. Okay, if your pelvic incidence is 40 degrees, you may need 40 degrees lumbar lordosis. If my pelvic incidence is 50 degrees, I will need 50 degrees. If Dr. Salim's pelvic incidence is 60 degree, then he will need a 60-degree lumbar lordosis. So we have to measure all of them before the surgery. If we have the custom made or the preventing rods, so we will have that lordosis during the surgery. This is the concept. This is the main idea. So you need a plan before the surgery.
And
And-
during the surgery, we need.
During the surgery, also you need it.
Yes.
Yes. Well, thank you very much. We learned a lot about adult degenerative scoliosis today, and I would like to thank you both for coming here and sharing your experience with us. So I'll wind this up now officially on behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato. I'd like to thank both speakers of today, Professor Mohammad Al-Ulama and Professor Onuri Yaman, as well as the chairs, Professor Nobuto Morota and Professor Salim Sentur, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 400 people who have joined us from around the globe on all three combined platforms of WeChat, YouTube, and Zoom. So until you all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.